This is the second part of the IBD talk, and what I'm titled this talk is An Aid to Managing IBD in Primary Care. Now, this is an abstract painting which I acquired in 1999. Now, that was the year that I was appointed to this job, consultant gastroenterologist. I was happy to be working as a senior registrar in St. Peter's, Chelsea. And this gentleman, Derek Turner, was doing his first art exhibition, interestingly enough, on the hospital grounds. I saw this painting, got very interested in it, and actually bought it off him. For two reasons. One, I liked it, but secondly, it's titled The Journey is About to Begin. And that was the month that I'd been appointed to a consultant, so it made sense to get this for my own purposes. But I show this because for most of the patients who have IBD, who come back to you, it's a journey. This journey is going to span over many years. For some of you, over 10, 15, 20 years or so. So the aim of this is to try and help illustrate some of the things that makes managing your patients through this journey easier. I'll structure the talk in this, and I hope to do it all in 20 minutes, hopefully. I'll be looking at how IBD needs to be seen as a multi-system condition, how different specialties or disciplines will help you. I'll list some practical approaches, how I do it with some sort of cases that I've come across, illustrating some points. I'll talk through some of the medications briefly, and then for some of the things that you see that sometimes we don't appreciate, to list some special situations of how to manage flares, pregnancy, mental health, and cancer in primary care with this condition. So, multi-system disorders are conditions that affect more than one organ system. We know of those, for some of these, like tuberculosis for the centuries. Syphilis joined this rank after the First World War. In the 1940s, connective tissue disease, with our understanding of immunology, we knew that lupus and vasculitis all come under this condition. HIV joined the ranks when it became an epidemic. But it's important to see IBD also as a multi-system condition. Because if you look at it that way, then it helps you to be able to flag out some of the problems that you'll be dealing with. This is a slide looking at dermatology. IBD can manifest in some cases on the skin, and also some of the treatments that we give can also appear on the skin as well. Sometimes you get a patient come to you, and they say, well, I'm on this treatment and I'm losing my hair. Well, when you have any pro-inflammatory condition, cytokines tend to inhibit hair growth, and you can lose hair from that. So that by itself can be a marker of disease activity. Sometimes the malnutrition that comes with this condition, particularly iron deficiency, can also affect hair growth and hair loss. We also give patients medications like mesalazine. One of the side effects of that is hair loss. But it's important that you are aware of this, because some of your patients are going to ditch their treatment purely because of hair loss, particularly the ladies. Dry, scaly skin can sometimes be a manifestation of malnutrition. This slide here illustrates somebody with pellagra. You may think you don't see it here a lot. But yes, it's not common here, but don't forget that some of your IBD patients, in their mindset that this condition is all due to diet, sometimes come to you with very weird nutritional supplements and diet that they are on, leading in itself to quite profound malnutrition in some cases. I've seen a slide already of erythema nodosum. Yes, this is a fleeting, painful rash that comes on sometimes on the legs, but it can come on anywhere. Sometimes it is the marker for your first diagnosis. Erythema nodosum can be caused by many different things. In the MRCP, the list is that long. But in the context of bowel symptoms, particularly irritable bowel, you need to think about inflammatory bowel disease. So not only can it help you to be able to unmask a new diagnosis, it can also help you to monitor your patients if their condition is not stable enough. This is pyoderma gangrenosum. Not common, but not rare. In fact, I've currently got a patient now who is being treated for that. High-dose steroids up to about 60 to 70 milligrams of prednisolone to control this condition. What you need to be aware of this is that pyoderma gangrenosum, even when the dermatologist diagnoses it, they will send the patient to a gastroenterologist. Such is the link between this and inflammatory bowel disease that you need to ask, have you got inflammatory bowel disease? And of course, if the patient has got this, unfortunately, in this case, my patient, I can't just convince my patient that this is all being driven by the inflammatory bowel disease. In fact, she's asked for a second opinion for an expert in pyoderma because she can't believe it. But it is the inflammatory bowel disease driving this. The mouth can be a good window for what's happening in the gut. After ulceration is a good discriminating factor between IBD and IBS. There are some patients who for years go with mouth ulcers, huge ones, or dental doctors and so on. But in some cases, that can signify what's going on inside the bowel. They can be on the lip, they can be on the tongue. Yes, other things can cause it. Herpes, celiac disease can sometimes give you this. But if a patient comes with colitis, you always ask them, have you got mouth ulcers? Sometimes can tell you whether they are stable or not. Beg your pardon? Now, chiliosis or slight dermatitis around the angle of the mouth. This is quite usual in patients with iron deficiency anemia. And you may think it's not common. Well, it is, actually. And because the patient's face is the first thing you see, if you notice these sort of changes around the lips, almost invariably the patient has got iron deficiency anemia. And in the context of bowel symptoms, you need to question whether there's something going on. It could be celiac, it could be Crohn's, and so on. And in the tongue, Crohn's is a condition that affects from the mouth to the back passage. Some patients have got granulomatous tongue involvement, but sometimes the deficiencies of vitamin B12 and folic acid can give you an inflamed or enlarged and smooth tongue. So that can also give you clues about nutritional status as well. The eyes are also important. There are some patients who will present to the ophthalmologist with episcleritis or iritis. I had a patient who had iritis going for many years. She used to exhibit her dogs at the Crofts dog show until it clued on to somebody that, well, she has got bowel symptoms as well. Eventually, we diagnosed Crohn's disease with capsule endoscopy because her ulcers were only in the small bowel, nowhere else. But once we got the bowel controlled, her scleritis is under control. Cataracts are not caused by inflammatory bowel disease, but I put this up because repeated courses of steroids eventually push your patients towards cataracts. And in fact, that's one of the myriad side effects of steroids that we try very hard to keep people on low-dose steroids so as not to be able to develop some of these type of complications. The cardiovascular system. Well, thromboembolic phenomena has become quite big in the news now medically. On the medical wards, we need to look on that. But in inflammatory bowel disease, clots are very common. The prothrombotic state can either give you DVTs, they can give you PEs, and in actual fact, when patients come into hospital now, I remember giving a talk recently about on the medical committee, we need to be giving them thromboprophylaxis. We say, well, but what about the bleeding? No. Despite the bleeding, we need to give them Clexane and so on to be able to prevent the development of clots. Now, the debate, I suspect, will shift into primary care because now it's difficult to give Clexane and so on, but some of our patients have got quite severe disease activity and are not in hospital yet. Maybe the oral anticoagulants, which are going to be coming online shortly, will let us now think about these for some of these patients, including the hydration and so on. In 1999, I was thrown into the deep end. One of my first patients was a young 21-year-old gentleman who was admitted with a stroke-like condition. She had a thrombosis in the sagittal sinus in the brain. That was due to actually his IBD, pancolitis. I'm pleased to say that after many years, he was able to walk. He got his maths and physics degree, and now he's in one of the space programs, I think European Space Agency. But it makes a point that you need to think about these to be able to help your patients. The urinary system is not spared either. Patients sometimes have fistulas into the bladder. Some of the patients, women, fistulation into the vagina. So a patient comes to you and say, occasionally, I'm passing urine and it feels like I'm passing gas in the urine. Well, think of a fistula. And the women, they may be embarrassed to talk to the male doctors, but yes, fistulation into the vagina is not uncommon. Renal stones can occur. Oxalate stones are interesting in that particular manner because the fat malabsorption in the small bowel makes a slightly higher concentration of oxalate delivered into the urinary system. They can crystallize and form these stones. And one of the patients that I look after at the Princess Royal, he has got huge oxalate stones in his renal tract. When you take an X-ray, it's like golf balls scattered along the renal tract. And that is due to these stones. But for us, of more importance is that because of the mesalazine, which has got about a slight tendency to push people towards interstitial nephritis, that's why we monitor their renal function every 6 to 9 months to make sure that we are picking the gradual deterioration of creatinine. The pre-renal dehydration and sometimes the stones can also predispose to renal impairment. So occasionally we send some of these patients to the renal physicians because we have to be sure, is the renal impairment due to mesalazine, which we know if we stop, the patient is probably going to relapse. Musculo-skeletal. Well, osteoporosis, you may think is just because of the steroids that we give to the patient. But cytokines on their own in high levels can push the bone towards weakness of the bone. So some of our patients, we need to look at their bone health carefully so that they don't go down this progression. Vitamin D deficiency presents with osteomyelitis, bone pain, but usually you will pick it up because the alkaline phosphatase is elevated. The rest of the liver profile tends to be normal. But you can do the suitable test for that. Some patients will come complaining of hip pain. This is sacroiliitis, inflammation of the joints. Now, joint discomfort in IBD is a very strange one because it can be on whether the disease is active or not. In fact, for some patients, you treat their IBD controlled, then they now start complaining of joint pains. And we haven't worked out that link yet. But interestingly, sulfasalazine, which is an old drug that I'll mention come later on, tends to be quite helpful for that, and the rheumatologist can help us with that. I mentioned this proximal myopathy because, interestingly, IBD, people are living longer. I've got patients in their 80s with inflammatory bowel disease. And when they flare up, we sometimes have to give them steroids. But the effect of steroids on the proximal muscles is quite profound, to the extent that I've had one patient who every time she went on steroids, she was confined to the ground floor of her house. She just could not go upstairs. But that's the effect of steroids that we have to think of. The liver, of course, the medications that we give, mesalazine and azathioprine, can affect the liver. But I showed this, primary sclerosing cholangitis, a condition where the bile ducts become strictured so that there is pooling of bile in the liver. People can present with cholangitis. Sometimes it can push them towards cholangiocarcinoma. But the importance of this is that once we pick it up, we've got to colonoscope the patient every year because of the strong tendency for this condition to be linked with bowel cancer. I picked up a 23-year-old newly diagnosed ulcerative colitis just 6 months ago, and I've had to refer her to the King's Liver Unit because within 6 months, she has developed sclerosing cholangitis, huge strictures in the liver, and she will most probably, as the years go by, perhaps end up with transplant. The endocrine system, we have to affect that every disease activity with nutrition and impairment can affect fertility. We are giving large quantities of steroids for active disease. Sometimes patients are pushed to be diabetic. We're having to cover them sometimes with insulin. We can do that, but they spend time in primary care, so you need to be aware. And also, if the small bowel is involved, you don't absorb things very well. So sometimes the medication that the patient is stabilized on for quite a long time suddenly becomes ineffective because the bioavailability is gone low. Iron deficiency is quite common. We have to look out for that. One 12-year-old that was referred to me with severe, significant iron deficiency with no bowel symptoms. Any question you ask me is fine. We did every test, couldn't find out why. Did a colonoscopy, had florid ulceration in his terminal ileum, no GI symptoms. 3 months later, mom came with IBS-type symptoms. She's also got colitis as ulceration. The point is that iron deficiency is never normal, and you must always think if they've got IBS-type symptoms, it could possibly not be IBS. Bone marrow dysfunction, I showed that because some of the medications that we use, like azathioprine, can affect the bone marrow, and that's why we monitor these medications the way that we do. Crohn's disease affecting the terminal ileum, that's the section where vitamin B12 is absorbed, and therefore, even though they may not be B12 deficient now, be looking for it. do every so often vitamin B12 levels because sometimes it can show up later. Now, a brief speech about medications. Steroids we use quite a lot. We tend to use between 20 and 40 milligrams once a day to be able to address flare-ups. It's best given in the morning in one go. If you spread it out, it disturbs the body's adrenal function. You have to tail it down slowly. One of the things that we see sometimes when you see the patients, you see that they've got a flare-up, you put them on steroids, but you wean the steroids down in 5 days. In 5 days, they flared up again. The steroids have to be weaned off slowly. Every 5 to 7 days, you're weaning down because that's the way that it responds better. You have to cover it with the PPI, and if there's going to be on for a long time, vitamin, calcium, and vitamin D. Mesalazine is the mainstay for maintenance, not so much in Crohn's disease, but beware in tailing down the dose too low in patients who've got pancolitis because they could end up flaring up. And nowadays, the goalpost for managing inflammatory bowel disease is changed. Don't rely on symptoms alone. What predisposes them to long-term complication is inflammation that is not down to zero. So if you're unsure, calprotectin can give you an idea about that. But this tendency about you start out high, you are good, so let's wean your medications down, we've got to be a bit careful about that. Remember that the patient's most distressing symptoms is the rushing to the loo and leakages and so on, rectal. So rectal preparations can be quite helpful to be able to help deal with that. Azathioprine we will initiate. We would prime them up with it. Remember, it takes 4 to 6 weeks to work. And then in this area, we've got a shared care approach where every 8 to 12 weeks, they have to have full blood count LFTs. Methotrexate, we don't use as much, but it's there. And occasionally, some of your patients will be on medications borrowed from the transplant program because we are unable to control them. Biologicals are the in thing. Currently, infliximab and adalimumab, these two have recently been licensed. We will prime them up, but I think the thing that I want to flag out to you is that the main side effects are infections. Nowadays, some patients are ending up with demyelinating conditions quite similar to multiple sclerosis. So if patients come saying they've got numbness, they are feeling weakness in the leg, refer them to the neurologist, possibly for an MRI. And the rare side effect of a rare lymphoma that is also being picked up in patients who are on biologicals, so we have to actively monitor them. It's changed people's lifestyle dramatically, but it comes with its own price. Just one slide on IBS and IBD. These two conditions are not separate entities. Sometimes, for patients who have got colitis in the rectum, proctitis, they tend to have a high frequency of irritable bowel syndrome. The reason being that when the rectum is inflamed, they tend to have proximal constipation in the upper part of the bowel, and that's what drives the irritable bowel. And if you don't think about it, you won't be able to sort this conundrum out. So it's not unusual for patients with proctitis to be on colitis medication and on Laxido, Fibrogel, Movicol to be able to help address the IBS side of the equation. So that 10% of people roughly with IBD will have IBS as well. Fertility in men. Well, sulfasalazine we don't use anymore. Mesalazine doesn't affect fertility. But azathioprine now we know do have some DNA changes in the sperm. There is no guidance as to what we should do. We have to discuss with the patient. There is no evidence that babies are being born with congenital malformations, and sometimes we think it's better for the patient's disease to be controlled. We are waiting for guidance on that. But in the case of women, the case is slightly different. It's important to note that when patients have got colitis and they get pregnant, we call it the rule of thirds. Some patients' pregnancy makes their colitis much, much better. A third of patients, no change. And for a third, very bad. In fact, there are some patients that pregnancy is the first time that they become aware that they've got colitis. But the principle is this. That we believe that controlling the colitis in pregnancy is more important than the effect of the medications, because the medications, congenital abnormality rate is no different from that of the general population. And we can use all of these medications safely. For one of my patients, I've had 3 children on azathioprine, and it's fine. The disease was controlled. Cancer and IBD, I think you've already heard about colorectal cancer screening. Sclerosing cholangitis I've mentioned. I just wanted to flag this up. the dermatologists are beginning to pick up a slightly higher trend for patients with melanoma and squamous cell carcinoma on people who haven't combined azathioprine and biological treatment. It's early days yet, but it means that interfering with the cytokine cascade may not be doing very well for the cancer pathway. Last 3 slides. Mental health. Now, of course, the condition can be distressing for some patients and make their mental state quite unbalanced. But we know that stress and life key points like moving house, getting married, out of job, and so on, tends to push some people's condition to be active. And if you plan for it, you can be able to help them through that. Some patients have got a personality and coping skills that don't gel well with this condition. Well, we have to deal with that. And then, of course, now we know that the brain has got quite a close interaction with the gut. There's a whole field of neurogastroenterology looking into that. So not only is the brain interfering with control of colitis, but the other way around. But we would need the mental health team, counselors, psychiatrists, life coaches, CBT therapists for some of our patients. And I've got patients who we're needing help from here to control them. But regardless of all of this, there are some patients who are just plain simply awkward. By that I mean, they've got their own mindset as to where they want to go, but you carry the can. And this next slide illustrates it very well. Esther Phillips is one of my favorite jazz singers, and she sings in exasperation about a partner. And it goes like this: I don't understand why you always go left when you should go right. It's like you're looking for something that you ain't ever going to find. That's the exasperation that we have with some of our patients. We know where they need to go, they know where they need to go, but they go that way. And then you are seeing them to say, well, how do you control my inflammation? And this is where, in this journey, the importance of your close relationship with the patient, pastoral care, you are their pharmacist, you are their partner, their brother, their friend, because this journey is going to be a long one. So, final slide. My concluding statements are this. I have described the multi-system nature of IBD. We need to look at it that way to help our patients. I have flagged out the different teams that can help us, but I think the main take-home message is this. I have made a case for long-term care grounded in the solid doctor-patient partnership, flexing this partnership to meet all the life different changes that happens along the way. Thank you very much for listening.